you going to be seeing? So whether this is ran by a clinical team within a healthcare group that you're currently working with, or if they want to rely on our team of LPNs and RNs, they're all US based as it is. As Lee mentioned, they're licensed in the state in which they're delivering care, depending on the non-compact, compact nursing situation. Not going to spend too much time on that. Just know they're 100% licensed in the state in which they're delivering care, and they have a very wide scope of care. Meaning if there's any a critical or abnormal reading, they're able to triage that and only escalate it to a clinician or a provider when necessary. So again, as you see, you'll see the first patient on here, the first view we see as I zoom in here is the unreviewed readings view. So in other words, which patients have used the device, taken a reading, but no clinician has reviewed that reading yet. In addition to that, you can see right here in the middle, the last reading. I know I'm zooming in here a bunch, just want to make sure you can see it all right. You can see if the reading's new with this red dot, this is indicating this patient has a new reading for blood pressure. And it's also indicating above that they're also on a pulse oximeter. So they might be on multiple devices. Tenovi supports a suite of devices that are obviously transmitting directly to our software once used. But point of this, more importantly, is the threshold of the reading. Is it controlled, uncontrolled, or critical? Our software will automatically rank the readings based on clinical necessity or how important it is to reach out to which patient at which point. So if there were 5 patients that had taken readings, for example, and 4 of them fell within the normal range, this patient would be ranked first because there's what's considered a critical reading. So we're going to click into a patient record, and we're first going to see the 2 different programs for this patient specifically that they're on, should they require multiple devices. A lot of patients are receiving 1 device, for example, but just to show you that you can be on multiple devices, we have the gateway as well that could operate or support multiple devices transmitting through the cellular gateway as well. We click into patient Wes here. We're looking at his blood pressure readings. So we can see when the new reading was. You can also see it up here. So the latest reading was 28 minutes ago, what the reading was, the average reading within the last 30 days, minimum and maximum. So for these providers, what's extremely important is you're monitoring patients, you're looking for trends, all of that's important, right? We're looking to see a better baseline reading for blood pressure, whatever their condition is. Lee mentioned earlier, this is also as important for these providers, right? They're tracking time, their team spending time. It's something that they should be reimbursed for doing. So our software will automatically track compliantly towards the billable codes for the remote patient monitoring program. We can see we've already hit 40 minutes here. 44 minutes, 49 seconds. So we've surpassed that 40-minute billable code, but it's showing us that we have yet to have the synchronous phone call. So this SYNC is still showing red. We need to contact a patient to speak with them directly. This will then automatically check to green. All of our calling, texting, note-taking is all done directly from the software. So if you see here, we have the ability to text, take your readings, text at any point. You send it, it'll send right at that point. You can call directly through the software as well. One of the really important pieces of running a remote care program is making sure your patients feel comfortable receiving calls, communicating, and engaging with the program. We use call branding with every group we work with. So we will use caller ID call branding to reflect the name of the clinic or reflect the name of the provider, whichever is a warmer introduction to answering a phone call. So that will show directly in the call branding from that line. But again, just know that you can call directly from the software, and it can also push a call to your phone if the computer doesn't have audio for some reason. After we click mark all is reviewed, this patient will fall off that dashboard we saw when we logged in. So the unreviewed readings view. Additionally, we're in the vitals tab now. We also have an FYI tab just for connecting points, talking points, things like that. So patient has a dog named Kevin, likes when we ask about him. I do have a dog named Kevin. That's not a joke, anyhow. But so just a talking point, bring up the dog named Kevin, might talk for a couple more minutes, things like that, make him feel more comfortable for that next encounter, that next engagement. We utilize patient tags as well. Just an easier way to filter, or if there's multiple locations for a clinic or multiple providers, again, an easier way to filter down to a specific list of patients. Clinical details. So providers or clinicians or anybody even relying on our team can add all of this information on behalf of the clinic if they want it in there. Active problems is always recommended, so it goes onto the billing report for when they submit, including the ICD-10 code. Or ICD-10 code is just the code in which a chronic condition is used for. So I-10, for example, is essential hypertension. There's a bunch of hypertension codes, but this would just go on to billing report for supporting the billing, essentially. We have a care plan tab as well. It's obviously going to be an extremely important piece of conversations for remote patient monitoring. How does their blood pressure affect their care plan or their plan of care, in general? But just an area to add additional clinical information for a patient. Programs that they're on. This is very important as you add devices per patients, or you want to change clinical defaults, for example. But Jay and his team set us up with a really neat opportunity to actually order devices directly from our software. So we can click on a device. Let me click on the right one. And then you can order a device directly through here to a patient's home. So you don't need to contact somebody to order a device. You don't need to go online anywhere to order a device. We have it set up directly in the software to ensure that you can order it directly to their home there. Enter a shipping information. That would be sent to whomever's email is entered here, just so you know when a device arrived. So clinical defaults as well, if you see.
So this is the clinician's user interface, correct?
You got it. Yep. So any MAs, anybody in the clinic can view this. If they're using our nursing team to manage the entire thing, they would still have access to this all the same. Our nursing team would just be managing the day-to-day. So if there's a critical or an abnormal reading, our nurses would recognize that, contact the patient, triage that reading, make sure they're not yelling at their grandkids like my grandparents, and they would have them take another reading, ensure it doesn't require the provider's attention. So they're only escalating the truly valuable readings, or the actionable readings that require their attention.
I see. So you sell this with nurses?
We do both.
Without.
Yep,
with or without. Well, that's different, right? Because that's different.
Yeah, our goal.
Davian, you put in the chat NTD, link of any action items.
Need to drop.
Yeah.
Oh. All right. I'll follow back up with you, and we can talk if you want to finish the deep dive next week. We've got a call on the calendar. I'll let Leslie circle back with you, and we'll either keep it or drop it based on what you want to do from here.
She dropped already, so but
I will circle back with her.
Follow up with her next week, because she decides. Her and Pam really decide. With Jeremy and I can influence, but they really are the decide whether or not. But go ahead. I don't want to interrupt.
Yeah, not a problem. And Gail, the one thing I wanted to mention, you brought it up, it's a great point, is you don't have to use our nursing team. Our goal for how we design programs or how we tailor programs is, obviously, we like to say, you tell us what to do. We consult in that, right? Mm-hmm. So not needs our nursing team. They might just need us to enable them to deliver the care, which is perfectly fine. So we have a great device partner that can deliver these in quality time and due time and set up processes that are extremely easy for the team. But it's our job to train their nurses to use that software, or our nurses could use it. It does not matter to us. We're extremely flexible there. We want to design a program that helps their workflows. We don't want to tell them how to do things necessarily.
So just for my edification, who is buying this? So who buys it with the nurses? Is it like geriatric or rehab facilities, or?
It's a great.
Let's come back to that. So I've got a section that will cover that.
Sure.
I'm going to make a note that we come back. Let's get through the software, and then we'll go talk about who we want to talk to for clients, because it's not what I originally thought. When I first built this, it was for one angle. And then as we got deeper into it, I was like, oh, wait, that's a whole thing. So let's just keep moving.
Perfect. I'm just running down here. Demographics is obviously very simple. All this information can be added, phone numbers to be able to call friends, family, the patient directly. If there's caregivers that are in the home during certain days, we can also add them as a contact to call them through the patient record as well. Interactions, we have a full history, a full log of all interactions with the patient, any readings that were reviewed during the period, if there are any text messages sent, calls made, and the note that was left for that specific interaction. Patient calls the front desk. It happens. They don't call back their monitoring number. Perfectly fine. You have the ability to add interactions at any point just to ensure that you're not missing anything. Maybe it's a 5-minute interaction. It was a synchronous phone call and patient called front desk regarding blood pressure readings, something like that. But you create that interaction. It's going to add it here. You can see as a manual interaction for the total time. Not a great justification, but We'll skip that for now. Once I click finish monitoring, this total 8 minutes will add or accrue to the total here. So we can click that. We can see that that patient fell off of the list of readings that need to be reviewed. Additionally, some other really neat adherence dashboards. These are going to be used regardless if it's our nursing team doing it or the clinic's nursing team doing it. Adherence-based dashboards. This is a great clinical program. Providers want to be paid for it. So which patients need a monthly phone call to ensure we're able to bill for the 457, 470, or 458 codes. Again, it's going to tell you which patients don't have that synchronous phone call. In addition to that, time adherence. Which patients have taken enough readings, but we just haven't quite reviewed for enough time? Non-adherence. Patients are just not taking readings at all. So these are patients that might need a bump. We might want to call them and set them up for automatic reminders. Our system uses reminders based on behavior. So if a patient is expected to take their reading by 2:30 p.m. in the afternoon, if they don't take it by 2:30 p.m., they would get a text reminder, an SMS reminder, an automatic phone reminder, a voicemail reminder. So those can be built in as well just to ensure compliance for a patient. Patient engagement, all of those in one view. So which patients are just not doing anything, basically. There's custom views you can create as well. So if you want to save a view, you can add different areas as well in the column. So maybe you want to see contact time. Days of the week they prefer to be contacted. That way I know which patients to click on. We can add this as a view, Jared's view, right? So the MA or the nurse or the doctor, whoever's in this software can have their own custom views. Task tab, you click on a patient, it'll bring you right into the patient's record. So if they send you a message before the, maybe after hours, you don't see it. Regardless, it's going to pop into that tabs view there or the task view there. Administrative, this is where you add users. So we have compliance-based logins essentially. So when you send a login to a patient or to a clinician or a member of the clinic, if they're a biller or whatever it might be, you can set their permissions. So they're a biller, they can download the billing report. Pretty simple. Are they a clinician? Are they a qualified healthcare professional or higher? Can they accrue time towards those billable codes? Yes or no. You can set that before you send the invite. Organizational details. So this is something we'd set up for each new clinic. So if you have 25 clinics, you'd have 25 different software setups essentially. And then you'd have a parent-child organization essentially. So you'd have whomever from your team you want to have access to every single group, you'd have access to that, but the clinics themselves would only have access to their specific instance of the software. This is where you add those patient tags, some nurses, locations. Pretty simple. Make a name, choose a category, choose a color, and what does it mean? And then clinical defaults. So you can set the defaults for a clinic across the entire patient base, or you can also change them individually. We use the standards for the society that's related to the condition. So blood pressure, we use AHA standards, but again, they can be changed for any clinic. There's a pulmonologist about 35 minutes from me. I go into the clinic probably once a month to see him, but when we kicked them off, he said, Jared, every single one of my patients' blood oxygen runs higher than this. Can we increase it across the board? So we increased his across the board, so he wasn't getting strictly abnormal or critical readings when that's where their normal baseline is. So that's also able to be changed. And then a billing dashboard. So as billable codes are met, we use the lowest reimbursement for the country to give you a conservative view on what your total reimbursement going to be that month. Billing reports can be downloaded at any point. So very simple for teams to download those billing reports themselves. They come out as a CSV file with data service, ordering provider, problem list, everything you need to bill, and the codes in which you can bill. Search patients from the software, patient calls, front desk, like we mentioned, like, Jared, I feel like I have high blood pressure. Like, oh, okay, looks like you are right. But regardless, again, you can search very simply in the software itself. And then we have a knowledge center as well. So if you just want to search blogs, submit a ticket, if a device isn't working, all that stuff, which Jay, that never happens. They always work. But no, just normal things. Or if you have like a recommendation, we have a software enhancement request. I want to be able to do X, Y, and Z. This goes directly to our product team. And then the blocks here, the working through how do you do certain things. So how do I check the enrolled patient count? It'll give you steps as how to do it and where to find it. That was a lot, so I'd like to pause Is there anything specifically that we were looking to see in the software itself? Anything you saw that was concerning?
No, it's a very comprehensive overview. Unfortunately, I do have to drop for something urgent that just came in. But as I said, so thank you so much. I think that's very unique that you bundle in the nurses, and so that could be a differentiator for us. And you know, this all works through Pam and Davienne. So but I
Absolutely. And we're
appreciate
going to be talking.
Jeremy looping me in, though. I do thank you, Jeremy.
You know, Gail, before you
Absolutely.
leave, it's great to meet everybody. I'll just one kind of closing thing. Number one, thanks. It's great to meet you. Number two, as you all sort of dig into this, there is a huge unmet need here. There's a lot of solutions that have like a lot of dots to connect till you get to success. This is one of them that is very, very simple, and there's clear ROI. So as we, you know, peel this one back, I'm excited to share where we're at. I mean, I've got a decade of experience in GE Healthcare and some other big companies, and everybody seems to have a solution here. This one, I can tell you, is growing so fast, and like the market numbers all back it up. So I think there's a lot of excitement. But
Yeah.
Well,
great to meet you.
do you have one more minute that I can share with you and answer the question of
I have
who
to
do we
drop at
target, who do we-
2:15, so, but
Okay, our point of contacts are really going into the physicians. It's going to be your geriatric groups. It's going to be your cardiologist groups. It's going to be your kidney disease and things like that. What makes this make sense is how much money they can make. And because of how the software tracks everything, this brings it down. The two things to come into play, if they get at least 2 readings a month, doesn't matter where they fall in here, they get $52 a month. If they have, which is kind of pretty much a requirement, the 20 minutes of monitoring care with management, that's not just talk time, that's also examining the reports and stuff. That's $41.
that's
Those two alone
reimbursed
are
back to
90.
the hospital, right? That's the
Back to
reimbursement.
the prescribing
Prescriber.
clinician.
Yeah, yeah,
Yep.
yeah. No, that's
So-
good that you guys have that expertise that we don't have. So that's excellent. Yeah.
Yep.
To be able to
So,
tie
Jeremy,
it
if
back
you wanna
right to the reimbursement. Yeah, I
Yeah.
gotta go, but thank you so much.
Yeah, and
Thank you.
Jeremy,
Gail.
or Jared and Jay, if you want to stay on with Steven.
Well, I
I don't know
wanted
if you
to,
needed Jeremy. Yes.
yeah, Jeremy is who the call was for to begin with. And so we kind of got a slow start a little bit. We had a lot of who's who in the zoo that showed up and said, so Jeremy, let's talk. What do you think?
Yeah, so I really appreciate the demo, and to be honest, my level of familiarity with competing RPM solutions, as far as the you know, the differentiated capabilities and the features that are important to my clients and whatnot, is limited. I'm trying to ramp up, and so that's why I find this so valuable. Like Gail said, you know, we do have a few other RPM solutions, but in the accounts that I'm supporting, the largest, in fact, there are, in our strategic account module, there are only about 10 of the largest provider accounts in the country. So it's your UHC Optum and Kaiser Permanente and HCA, and so we aren't having. I'll be completely honest. We aren't having RPM conversations with these accounts. They've got solutions in place, I'm sure, and we just haven't been talking to the teams that are responsible for that within these accounts. So it's not like I can, you know, turn this around and then go and talk to my guy at HCA that's in charge of their RPM solution and pitch it. You know, I'm not at that level really at this point, but it's really valuable for me to understand kind of more about, you know, how this solution works and what resonates with customers, and, you know, how we're going to go to market, and how I can start to try to have more conversations with the strategic accounts that I'm affiliated with.
Hey, Jeremy, would it be helpful if from a payer landscape, because we're seeing a lot of traction in this space. And so would it be helpful if we were able to come up with, say, like a one pager that like the benefits for RPM for some of those strategic clients?
Yeah, yeah, absolutely. I think, yeah, so yeah, you keyed in, Jay, to like really where I'm coming from is not just, how can I how can I sell the Premier Wireless RPM solution? It's more about how can I sell RPM and like what is, resonating and how, what are the leading solutions out there today? What's the competitive landscape? So just from my perspective, and Gail and Davion and Pam might be a little bit more up to speed on some of those things because they support the entire account portfolio, and not just those few accounts. So
I'm gonna guess they're not, Jeremy, because they support a gazillion things across the portfolio, whereas you're more specialized in the healthcare realm. And
Yeah.
so, one of my thoughts is I love the idea of Kaiser from the innovation aspect, right? And having that as a conversation. And I'm happy to fly out there with you at some point as well, or have the conversation remote, either one. One of the things that we were actually talking about, I don't remember who I was having conversation with the other day, but HCA, from looking at your strategic deck, right? HCA is unified. They're centralized, but not centralized. There's some things they have to do that are top down, but so many of the things that they do that they get to make at local levels. And I do know some people within HCA here in Houston, and maybe we can kind of talk through. I wouldn't want to do any harm, right? I don't want to go have conversations with people that somebody at TMO is having conversations with otherwise, but have a conversation about how to go slay the dragon.
Yeah. I'm
One at a
absolutely.
time.
I would love to work together in that way. Now, Jay, you mentioned payers as well. So are you seeing? Was that intentional? Did you say
Yeah.
payer?
No, I thought you'd mentioned
differentiated?
United, Optum in
Yeah.
some of the plans. Yeah.
Yeah, absolutely. So I mean, to give you a sense for the accounts that I'm supporting right now, it's HCA, Tenet Healthcare, Trinity Health, Providence, Ascension, Cleveland Clinic, United Healthcare, Mayo Clinic, Common Spirit, Molina, LifePoint, Encompass, Community Health Systems, and Amedisys.
That's
and
it? Those are the only ones?
That's all. Yeah.
Okay.
I couldn't write that fast.
So that and as you know, well, I don't think I mentioned Kaiser. Kaiser is in there as well.
Of course.
But
I think that's all of them. I think you did the top at least 6 of the top 10, and yeah.
Yeah, and a couple of those are both payer and provider, right? United Healthcare has their Optum group, and then Kaiser, of course, is all kind of lumped together, payer provider. So yeah, I mean, I think my goal would be to to look at a kind of a holistic strategy for how do we sell RPM into these largest strategic healthcare accounts. Is it even a reasonable target, or do these guys have it figured out?
Yeah, I think so one, like we're not going to solve it probably in the next 9 minutes, but this is an absolute real issue. I would say with 100% confidence that all of those accounts are doing some degree of remote patient monitoring. It's just a matter of where, how, and to what scale. And I'm sure between Vivo and myself, we have some clients and we've deployed 500,000 devices and have a lot of patients everywhere. So I think that there's a huge opportunity in looking at it on aggregate here to figure out what is the strategy here for an HCA. and can T-Mobile help implement that at a clinic-wide level? Or we could pick a couple to go from. Certainly Kaiser and the Permanente strategy is interesting. But there's really, I think it involves like a deeper strategic discussion to understand the financial components of it and the clinical expectations as well, to make sure that when you're having those high-level discussions, and I'm sure you have limited time with C-suite or whoever those call points are, you want to make sure that you know who you're talking to and the problems that they're solving, and we can be very pointed in our solutions as well. So at a high level, these are real issues that all of the systems are trying to take care of, right? When you start to talk about, hospital readmissions, you start to talk about managing patients outside of the hospital, and, really maintaining the healthy dose of sick patients that the doctors see and less time with the healthy patients. And that's sort of the big claim that RPM is doing right now.
Yeah. Yeah. No, I mean, we just met yesterday with the CEO of Optum's home and community care delivery organization, CIO and CEO yesterday. And frankly, RPM didn't even come up, but they did express great concern about, connectivity challenges and the need to provide better patient care and better provider experience. And so if there's an RPM angle there that I can introduce to add value and to help them deliver on those business outcomes, I would love to be able to do that.
Perfect. Yeah, I think when we're talking to
one of the things.
Go ahead.
Okay. One of the things, so to the point of, are they all doing something? They are all doing something, right? 3% is the saturation rate for connected RPM and RPM, generally speaking. The challenge is exactly what you said they were mentioning, and they came to you for connectivity. This solution ties it up with a little bow on it. And when we look at delivering it, what makes this work is the fact that it's connected. When it gets shipped to the home, they're going to open up their box, and it's going to be like Christmas morning. And inside the box is the little gateway that I showed you the picture of, and then their cuff, or their cuff and a glucometer, or right, whatever the devices are that they're going to be managing and stuff. It's there. It comes out of the box and it's ready to go. Yeah. And that's the key. So I think one of the things that I want to do is, and Jay, you and I can chat about it, is just, and Jared, we can come up with like how we build a couple of demo kits, and we give you a demo kit, Jeremy, so that you could go and show them that. I don't really want to give you access to the portal to go show, because unless you're an expert at showing the portal, I don't think, because I've tried doing the portal, I can't go through it as smooth as Jared can go through it and answer all the questions and have that high level expertise. But to show, open the box and have it go and get the reading right then and there, and be able to give that experience of being able to know that reading went, I think could be a game changer, because that answers what they said is that better level of care. The other thing that we can do with it is, one of the solutions that we've been providing in other space for quite some time is what we call CPR3, connecting people to the resources. Some of the individuals that they're going to have when they're looking at some of their poverty-stricken people, or they're looking at people that they're going to be poverty. They don't have a phone or internet in their home. One of the requirements is that they have communication. And if they're doing telehealth, they need face-to-face communication. So where are you based out of?
Utah.
Well, I hadn't been to Utah in many years. I'll come up there one day and spend a day with you and just walk through this on how do we package this? How do we bundle it so that you could go in and have a conversation? And then I'll work with Jay and Jared on making sure that we've got the right assets to support you to go have those as conversations and stuff.
Cool.
But
love it.
Yeah.
Hey, Jay, you're muted.
Yeah. One of these years I'll figure this out. I think it involved, like when you start talking, I mean, working with Optum, I mean, it's so complex, right? And it's such a matrixed organization. And so to really have a dialed in approach, because it's not going to be, here's RPM, you want to buy it. Like it is far more nuanced. But the payer space or that landscape is really, really interesting because they know more than anybody what that highest risk patient population looks like. They know, and they've got that allocation of dollars already pointed. So this is a project that can start small and we can get some easy wins, right? And then you really grow from there to get enterprise adoption. So it's sort of a language that we're learning how to speak, and I've got a payer expert that's on my team that I think we could, and we're already having not just discussions, but we're already involved with a number of payers and at-risk organizations that are seeing a huge return on getting that data fast, getting those physicians to intervene before they go to the ER, right? From a CHF patient population that says, hey, I'm a little short of breath, go to the ER, versus, hey, increase your Lasix or take your medication, or all these things that are done outside of the hospital. So there's a ton of low-hanging fruit. And the way that I always describe it is AI is helping us out and it's going to help a lot of people out. But before we start, just blasting AI into the entire healthcare system, there's so many easy things that we can do to make it more efficient. And so I just think it, like the story, if it's tight and with the access point of T-Mobile and Premier, I think we can, just accelerate things a little bit faster.
Yeah, that's great. I really look forward to working with you guys, and I think as a next step, I would love to see any if you put it together, any marketing content, but more specifically, like you mentioned, Jay, just kind of a primer maybe on RPM generally, and I mean, I could ask ChatGPT, but I think getting it from you would be more.
I have a document
useful
for you right now that I can upload for you. I'll just pop it right here in this chat.
Okay.
Jeremy,
It's a
what
high
events
level.
do you go to? Where will you be anywhere in the next 30 or 60 days?
Nothing on the calendar for the next 30 to 60 days. I mean, I'm at Vive and HIMSS and
Like,
we're
will you be at
evaluating a couple other healthcare related events, but nothing on my calendar right now.
Yeah, it's kind of slow. Yeah, we did Vive and HIMSS, and of course Health coming up in a bunch in the fall. I think I'm gonna be at ADA. Will you be at American Diabetes?
No, not planning to be there.
Okay. All right. Yeah, we can do this asynchronous, or if we need to get on a plane to be together, we can certainly do that.
I'll look at ADA and see, but yeah, no, that's great. I I support a team of, right now there's 6 principal partner executives that are actually, the account owners for these accounts. And our healthcare module includes not just providers and payers, but also pharma and med tech. So not all of them, this wouldn't necessarily be relevant to all of the reps that I support, but I would like to look at, once we kind of get our act together and have maybe a story to tell around RPM and how to sell, how to have a strategic conversation with their accounts about RPM. I'd love to set up a call with the sellers as well.
Absolutely.
Perfect.
So what I'm going to send you,
And also so Lee, we've got that sort of like generalized marketing slick. Let me put something together, Lee, and I'll let you send it over to Jeremy that has some specific use cases in the, like, specific to Optum. And maybe say, I'll pick a health system and try to go to keep it high level, but with enough detail to maybe be to have a hook to get more information.
Cool.
Okay.
So I don't know why it won't let me upload it. Jeremy, I'll send this over to you via email when we get
Okay.
off the call and stuff like that. And Jay and Jared, if you can hang tight for just a second, that would be great. Leslie, you can hang out too if you want.
All right,
All right,
thanks you guys.
Jeremy, I look
Look
forward
Hey,
to-
great to meet you, Jeremy. Thank you.
You too.
I look forward to continuing the conversation with you and stuff.
Same. Bye, you guys. Have a good
Thank
weekend.
you.
All right, bye. Hang on one second.